How's it going, guys? We have a difficult question for pathology. 22-year-old male, he's got a 1 month history of progressive left hip pain, difficulty walking, history of easy bruising, chronic fatigue, and his liver edge is palpable, and his left hip hurts him on physical exam. Fine. Now, this x-ray here, this is buzzy for avascular necrosis of the femoral head. Even if you don't know what you're looking at, we're looking at a femoral head that is not circular / spherical the way it's supposed to be, okay? This can be described as a contracted femoral head. You need to know that verbal description for USMLE because they often won't show you a picture and they'll say there's a contracted femoral head. Let's say a patient on glucocorticoids, patient with sickle cell, not the diagnosis in this case, but that's high yield for avascular necrosis. Now, I'll talk about this image as we move through. What's most likely to be seen in this patient? Choice A, CD5 23 positivity is wrong. This is for CLL, chronic lymphocytic leukemia. They don't have to mention smudge cells. CLL will be the answer when you have an adult who has a super elevated leukocyte count or it's all lymphocytes. So say 65-year-old dude, leukocyte count is 80,000 and it's 91% lymphocytes. That's CLL. If they give you a kid with the same labs, that's ALL instead. So in CLL, not just smudge cells, not just CD5 23 positivity of B cells, you can also get warm autoimmune hemolytic anemia where you get IgG antibodies against RBCs with a lower hemoglobin. Wrong fucking answer. Choice B, CD15 30 positivity is wrong. B cells. This is Hodgkin. And this is describing the Reed-Sternberg cells, the owl-eye appearing cells. In 100% of Hodgkin questions, they will start off by telling you that there is a teenager / young adult with a painless lateral neck mass or a facial swelling, which is lymphadenopathy. Then they throw in other descriptors such as hepatosplenomegaly. They can say there's a mediastinal mass, which is not thymoma, it's mediastinal lymphadenopathy. They can mention palpable supraclavicular lymph nodes on the right. They can also mention on the left as Virchow node, Truccio sign of malignancy. It's not limited to gastric cancer. And that's going to be Hodgkin. They want for 2CK3, lymph node biopsy is the next best step because you're looking for the Reed-Sternberg cells. And then tangentially for CLL, as we already talked about, they want quantitative immunoglobulin assay as the next best step. Choice B, wrong fucking answer. Choice C, deficiency glucose cerebrosidase with buildup of glucose cerebroside for Gaucher, correct answer. Extremely bizarre question here. Okay, when I wrote it, I'm like, what the fuck did I even write here? But you're looking at a crumpled tissue paper macrophage. Holy shit. It's not super high yield, but I'm just telling you what you're looking at. Some of you have heard that descriptor before, the crumpled tissue macrophage for Gaucher. And it's the answer in USMLE when you have a lysosomal storage disease where you get a bone problem, such as avascular necrosis of the femoral head. Now, some of you think, oh, it has to be a kid. There's many different types of Gaucher, and the most common type is actually adults, and it's usually asymptomatic. If they give it to you in a kid, you can have neurodegeneration, etc., but it can absolutely occur in adults. So once again, it's the answer in USMLE when you have a lysosomal storage disease where they mention a bone problem. It's a rare cause of avascular necrosis of the femoral head. You have to be thinking about things like chronic glucocorticoid use causing it, as well as sickle cell, or in a kid 5 to 8, you want to think of leg calf parathes, that's idiopathic avascular necrosis of the femoral head. Crumpled tissue paper macrophage is accumulation of glucose cerebroside, fatty substance within the macrophages. So let's just knock out the other ones. Increased serum LDH is wrong. LDH, and if you've been following my content, you know I really like this because it shows up a lot on NBME material. This can reflect hemolysis. So, for example, if they give you a vignette of G6PD deficiency with hemolysis, and they say LDH is high, that just means hemolysis because RBCs are packed with LDH. It's also a non-specific inflammatory marker. You can see it elevated sometimes, even in Hodgkin malignancy. Wrong fucking answer. Choice C, 922, translocation, Philadelphia chromosome, BCR-ABL, oncogenic tyrosine kinase fusion protein. Wrong fucking answer. Okay, so you're going to see a motley mix or a soup, a medley on a smear, which is your metamyelocytes, promyelocytes, and just regular myelocytes. So that's CML. And you're going to treat with imatinib, which is going to target the BCR-ABL tyrosine kinase. Wrong fucking answer.